Alright, welcome back. Our next lecture is on macrolides and sulfonamides. So by completing this lecture, you'll be able to describe the different subclasses of the macrolides and the sulfonamides, compare and contrast the mechanism of action of macrolides and sulfonamides, identify the types of bacteria commonly susceptible to macrolides and sulfonamides, list the common clinical indications for the use of macrolides and sulfonamides, discuss the different dosage forms and rules of administration available for each class, and understand the potential drug interactions associated with the macrolides and the sulfonamides. Let's get started. We see macrolides, the key oral antimicrobials for respiratory drug infections. They are bacteriostatics, so therefore that means they impede bacterial growth, so they stop the bacterial multiplication processes. Structure, they are macrolacton ring. They have macrolacton ring with deoxysugars. Therapeutically relevant rings, they have also 14, 15, and also 16 membered groups. So this is the structure. Okay, example of macrolide, we have the 12 membered ring. It's called metamycin. We have the 14 membered ring. It's the erythromycin, A, B, C, and other categories. We have the semi-synthetic derivatives, clarithromycin, erythromycin, fluoritromycin, and also oxytromycin. We have the 15-member ring is the azithromycin. And then we have the 16-member ring, which is the spiramycin. All these are classified according to the contents of their chemical structure and component. Okay, let's look again at the macrolide structure here in the next slide. So here we can see the three characteristics: the macrocyclic lacton ring, 14 or 16 carbons, ketone, and also hydroxyl groups. So we see the ketone group here, if we can remember in our organic chemistry. Okay, but sometimes when they undergo oxidation and reduction reactions, this one becomes a hydroxyl group. So okay, when a hydrogen is attached to the oxygen group. The oxysugars are also attached via glycosidic bonds. We have the mechanism of action. They inhibit protein synthesis by targeting bacterial ribosomes. They act on the ribosomes. Generally, they are bacteriostatic, okay, but they can be bactericidal at higher dosages. They bind to 23S ribosomal RNA on bacterial 50S subunit and inhibits the transpeptidation and also translocation step. So in the bacteria, we have the ribosomes numbered 23S and also the 50S. So these are the sites where to which this drug attacks. Okay, they are attached to this. That's its action along those ribosomal units. Concentration and transport actively concentrated within lymphocytes, okay, within the white blood cells. So they are transported into the site of infection and mechanism of resistance. They are enzyme-mediated binding site alteration or mutation, enzyme detoxification of the drug, and then active efflux of the drug. These are the mechanisms through which the bacteria can have resistance to these particular drugs. Is almost not different from the other mechanism we discussed earlier on already. Therapeutic uses of macrolide antibiotics. They treat infections caused by gram-positive bacteria, for example, the Streptococcus pneumoniae, and also limited gram-negative bacteria like the Bordetella pertussis and also Haemophilus influenzae. They are used for respiratory tract and soft tissue infections, medical conditions associated with macrolide antibiotics like Babesia infection, okay, bacterial endocarditis, prevention, Bartonella infection, bronchitis, Barlow's pharyngoid infectigo, Campylobacter gastroenteritis, cervicitis, Sancharoid, which is an STI, chlamydia infection, also another STI, Clostridium diffusing infection. So this is the range of infections that this drug is effective against. Uh, Still continuing with the therapeutic use of macro antibiotics, we said chronic obstructive pulmonary disease, cystic fibrosis, dental abscess, gonococcal infection, granuloma inguinale, Helicobacter pylori infection, Legionella pneumophilia infection, Lyme disease, Lymphogonorrhea gonorrhea, Mycobacterium ambium, Mycoplasma pneumoniae, non-gonococcal urethritis, ocular rosacea, otitis media, PID, okay, the pelvic inflammatory disease, phalangoid, pertussis, pharyngitis, pneumonia, rheumatic fever, prophylaxis, sinusitis, skin and structure infection, skin and soft tissue infection, sexually transmitted disease, prophylaxis, and strep throat. So you see, it's really a wide range of infections. So these drugs are really uh, of great importance. Um, Still continuing with the therapeutic uses, we say we use them in streptococcal infections, syphilis, early stage tonsillitis, meningitis, toxoplasmosis, even in typhoid fever treatment, and also upper respiratory infections. Contraindications, let's look at contraindications of microlide antibiotics. We need to avoid this medication in patients with prolonged QT interval. QT interval is this is an interval in the function in the cardiac function. So when we measure cardiac function, there's what we call the interval using the ECG, okay, the electrocardiogram. Uh, so those with long QT syndrome and type 2 and also using class 1A or 2 antiarrhythmic. So if somebody is on, these are antiarrhythmic drugs that are used to normalize the cardiac rhythm, like somebody who is having abnormal heartbeat, abnormal heart rhythm because of uh, abnormalities in the heart, they say we need to avoid this drug in those particular patients because otherwise it will worsen. Okay. A potential interaction with carbamazepine. So if we are giving somebody carbamazepine or cyclosporine or trefenadine or estomidazole or tefillin, tefillin is an asthmatic drug. Carbamazepine here we normally use it for anti-epileptic drugs. As a treatment for epilepsy. So if you are giving this particular patient these drugs, at the same time you're supposed to give macrolide, you need to be cautious because it has interaction with these drugs. We also use it in person, in pregnancy due to potential adverse effects on the mother and also the newborn. Still with the adverse effects, we said common gastrointestinal side effects like nausea, vomiting, abdominal pain, and also diarrhea have been reported with this drug. The prolonged QT interval predisposing to arrhythmias, especially erythromycin, has this effect. Okay. We have what we call the sensory neural hearing loss has also been reported from patients taking this drug. Serious side effects like the Stevens-Johnson syndrome, which is an allergic reaction, toxic epidermal necrolysis, hepatotoxicity, especially in pregnancy, and pyloric stenosis in newborns. Interactions avoid with colchicine, prevent the toxicity. Erythromycin was first discovered microladue since 1952 and produced by Sacrophornisopora erythraca, Eritrea, as the name suggests, is available in various forms. We have the IV form and then the topical forms and also the eye drops. We also have erythromycin eye drops, by the way. It's associated with infantile hypertrophic pyloric stenosis in infants, so that's why we need to be very careful when we are using this in pregnant mothers. Um, Pharmacokinetics absorption is oral absorption and degraded in acid environment, and that's why we use them orally. That the distribution they are found in body fluids and even can cross the placenta. Metabolism is through liver, hepatic fast metabolism and metabolized by the cytochrome P43A4 system. Elimination excreted in the bile and some minimal excretion occurs also in the urine. Adult dosage oral is 250 per milligram after every 4 to 6 hours. After every 6 to 12 hours. Can also be given IV with this calculation of 15 to 20 milligram per kilogram per day with the same frequency. Per day for this case, not the same way in the oral form. We look at Its formulations, we have oral tablets, and also ophthalmic ointment, and also the topical gel solutions. The next is clatromycin. Clatromycin was developed in 1980 and approved in 1990, derived from erythromycin, 6-O-methyl erythromycin. It has less GI side effect, gastrointestinal side effect due to improved acid stability. It can be bacteriostatic and also bactericidal. The mechanism of action, it inhibits bacterial protein synthesis by binding to the 50S ribosomal subunit. Remember, the other one was binding to 23S, but here this is where clatromycin acts to the 50S subunit. Metabolism is converted to protein hydroxychloromycin and inhibit the cytochrome Phe3A4 and also the Phe glycoprotein. Pharmacokinetics well absorbed, distributed widely, and metabolized by those cytochrome system and excreted in urine. Toxicity symptoms include diarrhea, nausea, abdominal discomfort. It may also cause pseudomembranous colitis and also some allergic reactions. Dosage is oral, 250 to 550 milligram every 12 hours. Extended release tablets are there, 1000 milligram every 24 hours. Formulations of clatromycin, we have oral tablets, 125 milligram or 250 milligram or 500 milligram extended release oral tablets. Also, further for reconstitution in a combination of 200, 125 milligram for milk is the oral syrups for the children. Azithromycin was discovered in 1980 and approved in 1988. It's a broad spectrum, effective against gram-positive and also gram-negative bacteria. It had been studied extensively for COVID treatment. You remember during COVID-19, and we start to debate about why sometimes people are using antibiotics for COVID-19 treatment, which COVID we know is a viral infection. But this debate was getting longer and endless, and of course, COVID was teaching us new things that we have never learned in our lives, so it was quite a new scenario for all of us. Mechanism, it binds to 23 subunit ribosomal RNA and also inhibits the protein synthesis. Azithromycin pharmacokinetics bioavailability in 37% and widely distributed in tissues, metabolized by the cytochrome and eliminated through bile and urine. Side effects, GI disturbances, oral thrush, yeast infections. Okay, it can also lead to these are fungal infections. Dosage 500 milligram once daily for 3 days. Child 10 milligram per kilogram once daily for 3 days. It's not for use in children less than 6 months old. Formulations of azithromycin, we have the oral tablets, okay, with those milligrams specifications. We have the fodder for injection, and also have the fodder for reconstitution. Uh, Macrolides nursing considerations. Monitor the skin, watch for any signs of skin reactions such as the rash, itching, hives, which may indicate an allergic reaction, and then we can report if the skin changes promptly to the healthcare provider. Monitor also boil signs, keep track of the boil habits, and report any changes such as diarrhea or abdominal pain, which are common side effects of macrolide antibiotics. Ensure adequate hydration to prevent dehydration due to diarrhea. Monitor also the laboratory results, especially liver enzymes, regularly assess liver function tests, especially liver enzymes like aspartate, AST and ALT, okay, this is aspartate and also the alanine transaminase, aspartate transaminase and iron transaminase macrolides can rarely cause hepatotoxicity. They report any significant elevations promptly to the healthcare provider. Good option if person is allergic to penicillin. Macrolides are suitable alternative. So if we are dealing with a person that's allergic to penicillin, and then we know this person may not need penicillin because he may become allergic, normally macrolides can act in the place of penicillin. And many times we use erythromycin for patients who cannot be treated with penicillin because of allergy to penicillin. Mechanism of action, we have bacteriostatic action. They inhibit bacterial growth rather than directly killing. So they are not bactericidal, they're just bacteriostatic. They prevent the synthesis of folic acid required to synthesize purines and also nucleic acids. They do not affect human cells or certain bacteria that can use preformed folic acid. They only appear organisms that synthesize their folic acid. Indications of sulfonamides, they treat both gram-positive and gram-negative bacteria. They are effective for pneumocystis jirovecii pneumonia, which affects HIV patients many times. Used for upper respiratory tract infection and also treatment of urinary tract infections. Adverse reactions to the sulfur drugs, sulfonamides, they can cause nausea and vomiting. Also, they have been implicated in causing rash, hypersensitivity reaction. Stephen Johnson syndrome are found like 3 patients during my clinical practice that responded to this with this reaction after being given this drug because the person did not know in the history and we didn't know anything about the reactivity of this particular sulfur-containing drugs. Hematology, we have blood disorders. There's Sagras means blood disorders. Neurological, we have kernicterus. Renal can also cause crastaluria, crystals in urine, and also renal damage. Sulfonamides interactions with other medications, sulfonamides can potentiate the effect of oral anticoagulants, leading to an increased risk of bleeding. Concurrent use of sulfonamides with methotrexate, which is an anti-cancer drug, a cancer chemotherapeutic drug, can increase the risk of methotrexate toxicity, particularly hematologic and gastrointestinal adverse effects. Sulfonamides can displace phenytoin, okay, an antiepileptic drug as well, from its protein binding sites, increasing free phenytoin levels and also potential toxicity. Sulfonamides also potentiate the hypoglycemic effect of sulfonylureas, leading to an increased risk of low blood sugar. So take care. They have the tendency to cause hypoglycemia as well. Sulfonamides can enhance the diuretic effects of diuretics, leading to an increased risk of electrolyte imbalance, particularly hypokalemia. So they can cause hypokalemia. Concurrent use of sulfonamides with memantamine can also increase the risk of crastaluria. So these are nephrotoxicity. So these are some of the side effects of these sulfur-containing drugs. They may also increase the efficacy of oral contraceptive by interfering with the enterohepatic circulation, leading to decreased estrogen levels. So once given together, it minimizes the action of this contraceptive, and otherwise it can cause failures. You might conceive unknowingly simply because this drug has countered the action of the contraceptive that you intended to prevent pregnancy. Sulfonamides can potentiate the risk of hyperkalemia when used concurrently with angiotensin-converting enzyme inhibitors. Nursing consideration, evaluate CARS and sensitivity test results before administering antibiotics. Take drugs, prescribe time intervals, maintain constant drug levels. Only adjust the dose with the healthcare provider's advice and complete the full course of treatment to prevent infection recurrence. Take drugs requiring an empty stomach before or after meals as directed. Differentiate also between immediate and extended release medications and do not alter the extended release forms. Avoid using sunlight or UV exposure during and after therapy and use sun protection. Take sulfasalazine with food or after meals. Expect orange yellow skin or urine coloration and contact lenses may stain permanently. Consult an ophthalmologist. So these are things you may also see changes in your urine. Okay, so don't get scared when you're taking this drug and you see orange yellow uh, color of your urine. With this, we have come to the end of this lecture, and thank you so much, and see you in the next lecture. Bye bye.